In my personal experience, as far as these issues that we're finding with hip replacement, what it has really shown me is how difficult it is to bring these to light within your own organization. I cannot get a podium to discuss these problems in front of orthopedic surgeons, either nationally or locally. There's a huge resistance to admitting that these problems exist, which is in one of orthopedics' otherwise most successful and touted procedures. But I'm from Anchorage, Alaska, largely in private practice. We have a decentralized medical school up there. I do a little bit of teaching in that. And I'm in private solo practice at this point. Okay, disclosures. I think this is an important slide, mainly because it's such a deficiency when I go to national orthopedic meetings. It flashes up for a second, and you don't really realize that the speaker has been paid millions of dollars by industry to develop the very implant he's discussing. And I don't have any financial disclosures. I've been embroiled in this topic one way or the other for about 10 years because I was actually the index case of systemic cobalt poisoning from a metal-on-metal hip replacement. It was something I later figured out had been previously described by other mechanisms. But metal-on-metal hips were quite popular about 10 years ago, and I got one and suffered what was thought to be a rare, previously undescribed complication, which we now realize is probably quite common. I not only was the index case, but I wrote up the case report, and I've had multiple other publications on that now, and I've been a speaker for the Safe Patient Project, and this is my second trip here. One of the points of my talk here is to give people an update on the issues specific to hip replacement, in that has changed over the past few years, in that the at-risk population has greatly increased, and I could say these problems apply to most patients who have had a hip replacement over probably the past 20 years. So the majority, before we were dealing with a fairly discrete at-risk population, I think this is an emblematic situation of the deficiencies in the United States of medical device regulation. And I think people need to realize that presently it appears that it's only going to get worse, because as Peter Eisler mentioned, the present situation seems to be markedly deficient, and the political forces are working on making it even worse, whereas even with the pre-market type situation, the companies would really only have to present anecdotal case reports of success rather than anything approaching a rigorous clinical trial. And as we'll get into here, the status quo is not acceptable, and making it worse is certainly not acceptable. And as Peter Eisler mentioned, there seems to be multiple layers of problems with the FDA, and part of the issues is that they're legislated almost to be ineffective. And I think a lot of this goes to political power structure and commercial interest. In terms of hip replacement, Dr. Wild was giving these great examples of high cost, poor care, low cost, good care. With hip replacements, it's really fascinating because we have very good data from total joint registries that the newer, more expensive implants are much more dangerous and less effective than even 1970s technology. So we've had this perverse evolution of hip implants to make them more complex, more expensive, less effective, and more dangerous. And this just goes completely counter to how everybody thinks. We're always primed to think that newer, more expensive is better. Certainly not the case in hip replacement. There's transparency issues in hip replacement as far as pricing of the operation. There was a study in JAMA that discussed just the enormous fluctuations regionally between institutions and regions as far as the cost of that procedure. About 1/3 of the cost of the procedure relates to the cost of the implant. And again, as I've just mentioned, the less expensive implants, the ones that have been around a while, have an established safety record, which is very, very good. And one can make the argument that if you have something that works very, very well, and if you innovate on it, and the innovation is more likely to make it worse than better, maybe you ought not to do that. And I'd also make the argument, particularly in the United States, that this is a very poorly studied area. Most of what we've learned about the shortcomings of total joint prosthetics in the United States comes from national total joint registries elsewhere, because we don't have a total joint registry in the United States, whereas England and Wales and the UK do, Australia does, Scandinavian countries have for a considerable period of time. And in those particular countries, the surgeon's choice of implant is much more constrained in this country. And by the nature, they're encouraged to use lower cost, established, and safer implants. This gives you an example. It's one of my former senior partners who really pioneered hip replacement in Alaska. He's holding a Charnley low friction arthroplasty that was developed and came into common use in the 1970s. And Declan was actually at Mayo Clinic when this implant was first being used in the United States, and was one of the authors of the initial 3,000 patients treated at Mayo Clinic with this particular procedure, a series that's now been followed out 40 years, and really demonstrates effectively that this very simple, rather very old technology is significantly outperforming the average hip replacement done in the United States today. And you can see the Charnley there was very simple, just 3 materials, bone cement. The femoral stem was one piece, and then a polyethylene socket that was cemented into the pelvis. And a lot of what's driven the misadventure of hip replacement has been the desire to have flexibility in the size of the head on the implant. And in the process of that, they changed the material to Chrome-Cobalt alloy because it's hard and makes a good bearing. And they made the heads quite a bit larger because there's some slight increases in stability when you do that. And it's that particular change that's really both the choice of the material from Cobalt and making the head larger has generated a lot of the complications that we're seeing in modern hip replacement. Regulation has been practically non-existent. There was really no medical device regulation when the Charnley came on board. It could be considered an antecedent device. And with the 510(k) process, basically all the manufacturers had to do was prove that their new prosthetic had a ball and a socket to have it approved as being substantially similar. And as these changes propagated over the decades, you wind up with devices that in no way resemble the Charnley arthroplasty, either in materials or head size. And there is the alternate pathway, which is pre-market approved device. To my knowledge, there's only about 2 hip replacements used presently in the United States that are pre-market approved, and those are 2 different hip resurfacings. And despite the fact that they're pre-market approved, they're underperforming most other implants because they're metal-on-metal implants. And the pre-market approval, despite the fact they're performing poorly, have severe complications and require premature revision surgery. The fact that they have pre-market approval is a major disadvantage to the patients that have them because the implant manufacturers have practical immunity from any sort of legal action. So in the case of hip replacement, the pre-market approval process was inadequate as the studies didn't cover an adequate period of time to reveal the shortcomings of the device. And then there was this other kicker that it really placed the patients in an unfortunate situation. And because of that pre-market protection from legal action, those devices are still being used by some surgeons, despite the fact that it's common knowledge that they underperform other technologies. This slide just gives you an idea how the implants have evolved from being very simple to being very complex. So now you have multiple materials and you have multiple modular junctions. You have the ability to use different head sizes, and different bearing couples have been introduced. And the Charnley was stainless steel ball rubbing on plastic. The particular representative implant I have to your right there shows kind of the worst case scenario of a modular, what we call metal on metal hip, where there's a chrome-cobalt inlay in a titanium shell. So there's a taper junction there that can corrode. Then the chrome-cobalt ball rubbing on the chrome-cobalt liner. So there's a potential for chrome-cobalt metal debris to be generated there. And then it's coupled with a modular stem where the neck is a separate piece. So now the stem is three pieces. You have a titanium stem, a chrome-cobalt neck, and a chrome-cobalt head. So you've introduced two modular junctions on the femoral side, which can both corrode. And this is what's generating a lot of the failures we're seeing presently. This is an example how more expensive and more complicated has been reflected in poor efficacy and higher revision rates. And when it comes to joint replacement, there's no such thing as a high-performance hip. The hip either works or it doesn't work. So revision rates are really about the only measure of efficacy of the total hip procedure. Patients are generally thrilled with hip replacements unless they fail and unless they have a complication. And so here's what you see with these new technologies being introduced: metal-on-metal resurfacing, or retaining a large ball, chrome-cobalt cap on the femoral head, chrome-cobalt socket liner press-fit into the pelvis. Premium technology, very expensive, has a failure rate per year or on a 5-year basis 5 times greater than 1970s technology. The metal-on-metal total hip, which used a stem, had more modular junctions, chrome-cobalt ball rubbing on a chrome-cobalt socket, 22 times rate of failure of 1970s technology. And then these modular neck total hips, where they made the neck a separate piece and that could generate corrosive debris, again, a rate of 22 times that of the Charnley arthroplasty. So more complex and newer, all bets is that it's worse rather than better. So for me, this started with the metal-on-metal hips. I had one myself, experienced the complications, was fortunate enough to have a research collaboration with Dartmouth Biomedical Engineering Center so they could analyze my bearing, look at the amount of metal wear there was, and we'll get into the systemic complications or cobalt poisoning from hip replacement in a bit. But this was the implant class that we recognized was high risk. And my case report was published in 2010, despite the fact, after 13 applications to the American Academy of Orthopedic Surgeons to present this information to our annual meeting, the Academy has recognized that this problem exists. I've never gotten a podium, and these implants now are basically off the market. But this was represented to me as how difficult and how long it takes to get this message across, and how much resistance you can have within your own specialty. What's the new kid on the block is the taper corrosion problems. So a lot of people, certainly orthopedic surgeons, are aware that metal-on-metal hips are an issue. Only 90,000 of those were recalled, about 1 million were put in, so we still have a huge population out there that's not being screened for the metal-on-metal problems. But then the next thing we started noticing, because of a particularly poorly designed implant, is corrosion of the modular junctions if one of the parts and pieces is chrome-cobalt, can be equally as problematic as the metal-on-metal hips. And this is a concern because we've been using modular chrome-cobalt heads on hips since I was in training. and that was 30 years ago. It appears that there's been changes made that have made the problem more frequent and more problematic, but in part, probably this was an unrecognized problem and only now recognized once the pump was primed by recognizing the metal-on-metal problems. But this is one of my patients. I did his primary hip. He had no symptoms at the hip, but he did have corrosion at the hip, which had stimulated a pseudo tumor, which was pressing on his sciatic nerve. That was a problem at the hip, but it wasn't perceived as being a problem at the hip, and he wound up with a laminectomy. He also had a huge amount of bone absorption around the top of the hip, so I had to go in and revise him, one, to get rid of the Chrome-Cobalt ball, to get rid of the corrosion problem, but also to bone graft his proximal femur so he didn't break his stem. He was a guy who was probably exceptionally sensitive to the Chrome-Cobalt debris because his systemic blood cobalt level was not particularly high. And there's usually blood cobalt is 1 or 2 orders of magnitude less than the cobalt levels around the hip. You can effectively monitor patients that have metal-on-metal hips or hips with modular Chrome-Cobalt components, which comprise most of Americans that have had hips done in the past 20 years. There are some exceptions, and it's becoming more and more popular to use a modular ceramic head and to not have any Chrome-Cobalt components in the prosthetic hip. However, this has been a very recent evolution over the past few years. So if you have a patient that comes into your clinic and they have a prosthetic hip, odds are they have a hip at risk. Doesn't mean they have the problem, but they likely have a hip at risk. But if you have a patient that does have symptoms of the hip or does have compelling symptoms to suggest systemic cobalt poisoning or cobaltism, it's relatively easy to check for. You can get a blood cobalt level or you can get a urine cobalt level. And cobalt is not very common in the environment unless you work in industry. Occasionally, people will be taking some supplements with cobalt, but that's relatively rare. So if they do have an elevated blood or urine cobalt level, it does indicate that either abnormal wear is occurring at their hip replacement if it's a metal-on-metal hip, or it indicates there's a corrosion problem if they have a modular Chrome-Cobalt piece. This is close to home to me because once I started looking for taper corrosion problems, even in implants that were not thought to be at risk, even within my own patient population, which is relatively limited, Anchorage, Alaska is not considered to be Mecca for hip replacement. My practice is focused on hip replacement, but I'm not a real high-volume surgeon. I like to spend time with my patients and time with them in surgery. But I also am kind of a referral expert for problem cases and revision cases, so I have seen patients beyond my own practice with this problem. But with the one implant that was recalled for taper corrosion problems, so you're dealing with a population that's been warned and supposedly systematically screened, although even when they have these recalls, I'm not sure all patients are notified or aware that they have a recalled implant. In the Alaska area, or the group practice I was in, nearly half of those patients have had elevated cobalt levels and have come to revision surgery within 5 years, predominantly for problems at the hip, tissue damage, necrosis, masses at the hip. But I've looked at these cases fairly closely, and it appears that a third of them also have a good story for systemic toxicity. And this mirrors our longer experience with the metal-on-metals in terms of number of patients, percentage of patients that get revised early, latency to symptoms, latency to revision, and the incidence of likely systemic effect. The difference is the patients with the corrosion have a blood cobalt level that's an order of magnitude less than those that had the metal-on-metal. And that makes sense because with the mechanical wear of a Chrome-Cobalt ball on a Chrome-Cobalt socket, you get microparticles. You don't get ionic debris. You don't get nanoparticles. Whereas when you're dealing with a chemical corrosive process, you're getting more ionic smaller particles or ionic particles. So the bottom line is the chrome-cobalt metal debris produced by corrosion seems to be inherently more bioavailable and therefore more toxic than this other metal debris that we are accustomed to from dealing with the metal-on-metal disaster. And again, those were systemically screened patients that was known to be a problem implant. Most of my patients have modular chrome-cobalt heads. It's not recognized that those are problem implants. Over the past year, I've started screening my patients when they come back to see me with implants that are thought not to be at risk. And what I'm finding is that they are at risk because they are having high levels of cobalt in their blood or in their urine. Certain percentage of those are having symptoms at the hip or systemic symptoms consistent with cobaltism. The big difference here is there's a lot more of those patients out there, and they're not being systemically screened. So I'm just kind of making a stab in the dark as far as incidence data. But from what little I've done so far in screening my own patients, and I'm at the point to realizing that basically I have to formally recall my entire hip practice from the past 10 years. So that's about 600 patients. Is that probably about 10% of them will develop at least elevated cobalt levels. Doesn't mean necessarily they'll develop a problem at the hip or the systemic toxicity, because there's a lot of other factors that might go into that. But there does seem to be a longer latency with the implants that haven't been recognized yet, which makes the problem more difficult for doctors to diagnose or the patients to link their hip replacement, particularly with their systemic problems. Here's an example of the problem we're having with the metal-on-metal hips. They're not being done anymore. They've been silently taken off the market, but only a small percentage have been formally recalled. So most of the million patients that had these implanted aren't even aware they have a metal-on-metal hip. This is a lady that could be at this meeting. She's a 40-year-old nurse, so quite young for hip replacement. She thought she was doing great with her hip because she would see her surgeon in the hospital. They'd wave, "Oh, I'm so glad I have the artificial hip. I'm so much better." It wasn't until she sprained her back at work, came into clinic, noted that her hip was just starting to hurt and grate a little bit, that they checked her blood cobalt level. It was 63 parts per billion. They start to worry in industry when you get a cobalt level of 1 part per billion. Most people in this room have a level of 0.2 parts per billion. So her cobalt levels were quite high. The thing was she'd also developed depression, which had been treated with antidepressant medications, improved her depression, but she was developing progressive cognitive dysfunction where she was having trouble reading. And she also developed a rest tremor, which was making it hard for her to start IVs. And she was getting to the point with the cognitive dysfunction that she was worried about her safety as being a nurse. And having been through much the same experience myself, I could really empathize with her. But because she was not being systemically screened, she had about 48 months of surplus systemic morbidity before she was revised to a ceramic on plastic hip. Her cobalt levels went down, her cognitive dysfunction resolved, as did her depression. She's presently off medications. This is one of in our series, this is probably our most spectacular case of neurocobaltism. This gentleman had 2 metal-on-metal hips. He did have a family history of Parkinson's. He was a commercial pilot. About a year after his first hip, and about the time his second hip was placed, he developed rampant progressive Parkinson's disease to the point where he had to give up flying, lost his flight service, couldn't be controlled on drugs, went out of state, got a deep brain stimulator, still poor control of symptoms, also got depression, cognitive decline, high frequency loss, tinnitus, and he thought he was going nuts. He didn't develop pain at the hip till pretty late in the game. When he came in finally to his surgeon, it was recognized he had metal-on-metal implants. These were not recalled metal-on-metal implants. This is a brand that was never recalled. His blood cobalt level was 116. His hips were sequentially revised, and within a year, his Parkinsonism all but went away. This is a corrosion case. This is a recalled Stryker rejuvenate, an older lady, and I'm really concerned about the geriatrics because what I'm seeing suggests that the geriatrics are more sensitive to the cobalt. Also, the geriatrics are difficult to tease the cobaltism apart from what we expect to see with aging. Because so many of the symptoms we see with the cobaltism, we see in people as they get older. But this lady had significant weight loss, progressive fatigue, poor sleep, nausea, deafness, myalgia, cognitive decline. She also developed cardiac arrhythmias and diastolic dysfunction. And the heart may be the most sensitive tissue to cobalt. Any hypermetabolic cell or cell that has high degrees of calcium flux tends to accumulate the cobalt, which is a metabolic toxin, affects the mitochondria. She got revised. Most all those problems went away fairly quickly. This was my come to Jesus moment because this was my patient. I did his primary hips. These are not recalled hips. They're metal on plastic hips. They were not thought to be at risk for anything. He came in for a routine check, but he was starting to have some anterior hip pain, which is pretty classic for developing problems at the hip with corrosion. At this point, I knew about the corrosion issues. I checked his blood cobalt level. It was elevated. And I said, gee, we ought to get an echocardiogram on you because that was my protocol, because I've seen people with elevated cobalt levels have almost always had diastolic dysfunction on echocardiogram, which is a stiffening of the heart. And it's been kind of one way I've been looking at patients saying, well, your cobalt level is elevated. Do we really think it's doing you any harm? And I've been using the echocardiogram as one thing to try to make that determination. He drug his feet for a while getting the echocardiogram. And I was actually on vacation. I get a call from my nurses. On the phone, he's really pissed. Why is he pissed? Well, they won't let him leave the echo suite, and they're admitting him directly to the intensive care unit. Well, not only was he in systolic heart failure, he also had an asymptomatic proximal aortic dissection. And he really didn't have any risk factors for that. The systolic heart failure is clearly known to be a complication of elevated cobalt levels. The aortic dissection is not necessarily, but he was a weightlifter. And he did lift weights, and that is a risk factor. But since his hips, he's only been putting up 1/5 of the weight that he used to. And if you look at the pathology of cobalt toxicity, it does make cardiovascular tissue stiffer. So I believe his aortic dissection was probably also related to his elevated cobalt level. This is a gentleman who just had problems at the hip. And this is an example of what we call as a pseudo tumor. That's a sagittal image of his left hip, is the MRI image, and the red is this soft tissue expansion of his anterior capsule, which was giving him hip tendonitis type symptoms, which we commonly see with the problems around the hip. This is a different brand of hip. Nobody is aware that this particular hip is at risk. But I've seen multiples of those within my own practice that are in trouble. Last year, I had a couple medical students, and we actually hired an epidemiologist to try to look at the literature and try to better understand the syndrome of arthroprosthetic cobaltism or cobalt poisoning from hip replacement. And Dr. Gessner was kind of brutal to medical students. He really made them follow a very rigorous protocol for, I knew about 23 of these cases before they did their literature review, but he made them wade through 2,000 different papers. But we came up with 25 cases. And what we learned from those cases, and the other thing people need to know is cobalt toxicity and poisoning has been long recognized for 50 years outside of total joint replacement. It's also been described in industry. It's described in medicine from when they used cobalt to treat anemia back nearly before time. But most of these patients had sentinel hip symptoms, but not all. Peripheral or central cranial or peripheral neuropathies are common. Systolic or diastolic cardiomyopathy is common. Constitutional symptoms, weight loss is common, as is what might be considered a psychiatric type presentation. And then we see the hypothyroidism and the goiter generally mainly in the cases that have extraordinarily elevated levels of cobalt. The thing to know, these are all literature reported cases. I'm one of the 25. But as you would well know, anything that's reported in the literature is somewhat of an exaggeration. You're dealing with the worst case scenario. The majority of these patients were deaf, blind, in a wheelchair because of their peripheral neuropathy and their myopathy. One had gone on to heart transplantation. There was one fatality. And there was this particular arthroprosthetic cobaltism became the topic of one episode of House. And there was the same day, I think 2 years ago, in Lancet and New England Journal of Medicine, they had simultaneous case reports of severe cobalt poisoning related to hip replacement. And in the Lancet report, they credited House with the diagnosis. This is the doctor. And I'm actually responsible for the House episode. So I thought that was pretty cool. So that's a systemic thing, but most patients, the local complications are more of an issue, and the local complications are more common. And they're not minor because they're limited to the hip. This corrosive debris can, or the mechanical wear debris from the metal on metals, can just take out the soft tissues around the hip, and that can occur either with or without symptoms. So these are real revision challenges, because you can get in there. If the hip loses its capsule and loses its major muscle attachments, instability is a real problem. And of course, revision surgery is never a walk in the park. We generally don't get as good a results with revision surgery as we do the first time around. And revision surgery tends to be ungodly expensive. So how did this all happen? Dr. Saman asked me, gee, if these things are worse than what you're using, in the 1970s, why are you using them? The problem is it takes us time to figure out that there's a problem. These devices don't go through pre-market approval. And it's been a snowball type effect. There's been bad change after bad change after bad change after bad change. The one thing we do know is that some of the earlier technology worked very, very well. But I think it's totally against economic and commercial reality that any of the large companies, and you're talking a $10 billion a year market, are going to say, hey guys, we're just going to go back to a generic hip. It's just economically, it's not going to happen. Although I would argue that's the right thing to do. What happens is the problem gets recognized belatedly. The patients that are at risk don't get followed. And they try to correct the problem by making another change, which may or may not correct the problem, might potentially make the problem worse. So I think a lot of this has been market rather than science driven. I hope this crowd, who has ever watched Monty Python and Search for the Holy Grail? Okay, so sometimes this slide goes completely over the head, but the problems we're seeing with hips is like the killer rabbit. It's totally unexpected. So no one went out to design a bad hip. It's just these problems were not anticipated. There's a relatively long latency until the problem is recognized. And in this situation, these have been very, very significant. And it's not quite taking patients' heads off, but it does have the potential to make them deaf, blind, dumb, and require a heart transplant or even die of multi-organ failure. I think this is just a byproduct of American medicine. I think when you get into a commercially driven enterprise rather than a scientifically driven enterprise, and when you reward design surgeons with multiples of millions of dollars by designing these things and promoting them, this sort of mischief happens. I wrote a paper with a couple of philosophy professors at UAA. It's been presented, it hasn't seen print yet, but it's easily accessible online. that discussed my own personal experience with trying to get the metal-on-metal complications recognized by the American Academy of Orthopedic Surgeons. Again, 13 submissions for annual meeting, all turned down. My initial paper, in order to get it published in Journal of Bone and Joint, I had to do an end run around the section editor, who was a consultant for DePuy, who made my hip. When my paper did get published, it came out with a commission commentary by the Presidential Line of the American Academy of Orthopedic Surgeons, 3 of which were or had been consultants for the arthroprosthetic industry, 2 of whom were or had been consultants for DePuy, also made my implant. When I looked into the committees that rejected all my submissions to Academy, 75% were paid consultants of arthroprosthetic companies. And the majority of those were the companies that had a huge stake in metal-on-metal technology. When I went to the FDA, I was very fortunate. State epidemiologists in Alaska gave this the first light of day. We put it in the newsletter for State Epi. That was in the spring of 2010. The CDC picked up on it, and they said, well, we'll put that in our MMWR, I think, is that right? Which is a monthly newsletter about what's happening in infectious disease. So we went back and forth, tried to take a 2-page report, condense it into a paragraph, and things were flying back and forth between us and Atlanta. And then someone from Atlanta says, oh, this is a medical device. We have to clear this with the FDA. And, you know, the FDA basically gave us the middle finger and said, this is our turf, bug off. And this got me onto the FDA, and finally, only by going through one of the centers in Alaska, I got a phone call into the FDA, and they basically, I actually had a nice phone conference with them. A year later, they had a specific focus meeting on this problem. They didn't invite me. So I called them up and said, why aren't I on your panel? I'm the guy who wrote this up. And they said, well, you're not an expert. And I said, well, why? God, tell me, what does it take to be an expert? Well, you either have to be a paid consultant by industry, or you need to be furthered by your professional organization, which was the American Academy of Orthopedic Surgeons. So, so this problem of conflict of interest is pre-market, it's post-market, it's in academia, it's in publication, and it's in post-market, because the medical device failure reporting is basically non-existent. Going into this, I didn't know that these devices had no real vetting. I didn't know about the 510K process. I assumed as a surgeon and a patient that these things had been reasonably trialed. This is going to be an incredibly expensive problem, because you're looking at probably about 2.5 million Americans are at risk, either from the metal-on-metal wear or from the corrosion issues. The cost for the remediation is probably mainly going to come from Medicare, because many of these were higher demand patients placed before age of 65. Their revision is going to occur after the age of 65. And it's only the minority of these implants that have been recalled and litigated where the companies have actually paid for the remediation. So it's a huge problem, and most of it's going to come out of the public's pocket and not come out of the device pocket. So what am I doing for my patients now? Most of my patients are at risk. My present practice in joint replacement surgery is to use an older, very well-proven device that's made out of stainless steel, which is cemented in a lot of my patients. In the patients that have very, very hard, good bone, and some of my younger patients, I use an uncemented titanium stem, but I put a ceramic head on it, and I only use a stainless steel on plastic articulation or a ceramic on plastic articulation. And that practice is very well supported by total joint registry data. But if I have someone who's had a hip and they are at risk either because they're metal on metal or they have a modular Chrome-Cobalt head or another modular Chrome-Cobalt piece in their hip, I'm getting an annual urine cobalt on them. And if their urine cobalt is greater than 3 or their blood cobalt's greater than 1, Whether or not they have symptoms at the hip, I get a metal suppression MRI to look for a pseudo tumor. Because those can be without symptoms, they can be progressive, and they can cause a bad revision problem. As far as the systemic problems, I do much the same thing. Only when their cobalt level comes back higher, I spend a lot of time talking with them and doing a very compulsive review of systems, particularly for an orthopedic surgeon, which, you know, usually conversation is quite brief and limited. Average orthopedic surgeon clinical encounter post-op. How's the hip? Great. So long. But you have to talk to these people about what else has happened to them medically. Have they developed hypertension? Do they have dyspnea on exertion? Have they developed new depression? Have they gotten increased forgetfulness beyond which you'd expect with normal aging? And in those that ring some of those bells, I'm getting a baseline echocardiogram that I can follow over time, and baseline audiogram, because that's something that's quantitative, can be followed over time. And in the patients that really seem to have cognitive dysfunction, I try to get neurocognitive testing, but it's very difficult to do because it's quite expensive. So that's pretty much the story. Call out to Dartmouth Biomedical, who's been a real partner in learning all this. And again, a warning that we seem to be going the wrong way as far as regulation is concerned.